Sony, please turn on the sharing. Can everybody see it?
Dr. Anurag, how are you doing?
I am good, sir. Thank you. How are you?
Yeah, good, good. It's my pleasure to be around. I've just reached, just touched my home.
Yes,
So I'm
yes, I
just, in
understand,
a
sir.
very raw condition. So,
No, no, no,
but
sir. You are
it's
always
so
smart.
bright, so bright. So I think it's my pleasure to moderate a topic of my taste and choice.
Yeah.
And who better than talking you about the topic?
And who
You
better
know,
than you moderating
no,
this session?
no,
You are
no.
going to
It's a
be so
pleasure to hear.
valuable.
I think I'm going to learn few things, and it's just such a important thing. And you're one of the brilliant minds, doing such a good work in MIPC all
Thank
across
you,
India,
sir.
and in a very important post, with
Thank
from
you,
such
sir.
an important position and post. So I
This
think
is
it's going to be
this
very, very
is
useful for
blessing of.
everybody who's listening to you, including me. I think
Yeah.
I'm too going to learn a lot
Thank you.
today.
No, nothing nice, sir. So
Yeah.
kind of you. So with your
Uh,
permission, sir, should I start the class?
Yeah,
Uh,
please go
yes,
ahead.
yes,
As I mentioned, I just entered,
yes,
so I'm
yes.
not all prepped, but anyway, but
It's
it's
all.
such a good topic. So please go ahead, Dr.
Yes.
Narag. And
So,
and I think to introduce Dr. Narag, everybody knows across India about you and me in subcontinent. So I think I
sir,
have, just few words. He's honorary secretary of the ISSP, the flag bearer of the Indian Pain Societies or the pain physicians across India, and I'm so happy that in holding such an important position in the ISSP in very good hands with Dr. Anurag around. I'm so pleased that future is good, and I think we're going to hear from you. A very important topic. I told you it's very close to my heart, and I'm very happy that going to talk about it. Thank you so much for accepting this topic. Thank you so
thank you, sir.
much.
So thank you, IAPM, Indian Academy of Pain Medicine, Dean Madam, Dr. Madhuri Lokapur, Registrar, Dr. Pankaj Surange, today's coordinator, Dr. Anshul Agrawal, and most important, today's moderator, Dr. Neeraj Jain, who is the pioneer of the topic today. I am honored to be present in his presence. So, dear fellows of very prestigious fellowship of pain medicine in India, that is FIAPM, I welcome you all, and I hope that you are going to be little bit stimulated. On most of the, you must be practicing and seeing, assisting your mentors during your fellowship. I hope that we will add something to it. So, so the to start with the title of presentation is vertebroplasty, and the full name is percutaneous vertebroplasty and percutaneous balloon kyphoplasty. Yeah, balloon kyphoplasty, as you can see with the BKP, balloon kyphoplasty, PVP, percutaneous vertebroplasty. So these are the minimal invasive pain spine intervention, MIPSI as we call it in our India. And now the word is also embracing this our terminology rather than injection and blocks for the as an umbrella term for the interventions which we do in the pain medicine. These are minimal invasive image guided MIPSIs used to stabilize fractured spine in the simple terms and to relieve pain from a vertebral body fracture. So you can see whenever a bone is fractured, it is important to stabilize the fractured part so that the healing gets better, the pain get reduced, and the quality of life get better. So it happens with all the bones of the body, including femur, humerus, now even the clavicle. So is the spine. So just a bit about that about what is the most common causes, what are the most common causes of fractures and indications of PVP and the balloon kyphoplasty. So the most common fractures which we pain physicians treat are the atraumatic compression fractures. And the cause we all know, that is osteoporosis, which is again can be of two types, primary and secondary. Primary is usually senile, that means age related, and the postmenopausal, after the menopause in the elderly females who are more prone for the osteoporosis. Second, there are few other causes, like one of the most common causes, GIOP, glucocortico-induced osteoporosis, GIOP. So it is also a increasingly common cause for the osteoporosis, and in result, fragility fractures like the spine fractures, like the Colles fractures, like the IT fracture of femur, intertrochanteric fracture of femur. These all are considered into the category of fragile fractures, fragility fractures. Then another cause can be osteomalacia, Paget's disease, and there can be another other causes like the multiple myeloma and metastasis in the bone. So I hope that we all know that the bone is one of very common site for all the primary malignancies to be metastasized, and which are many times very much painful and very difficult to treat condition. And then comes the hyperparathyroidism. So, little bit more about the osteoporotic compression fracture. Uh, as you can see, the first bone is a normal vertebra where you can see the cancellous bone, cortical bone, and densely populated cancellous bone. So, the sclerocytes are very much strong and in position. Second, you can see the osteoporotic vertebra where you can see that scant osteoclasts are there, and that this second vertebra, which is osteoporotic vertebra, is prone for compression because the body is not that much strength strong to sustain the pressures. And here you can see this is the classical osteoporotic compression fracture. So you can see the cortex is still intact, but the end plates are compressed. They have become more concave towards the body. So this is classical feature. So for this kind of bone, osteoporotic bone, not major amount of trauma is required to get fracture. Only a spontaneous or minor trauma. I hope that most of you can understand Hindi as well. I may use some words sometime. Like माता जी आती हैं कि क्या हुआ था, बाथरूम में जोर से पैर पड़ गया था. Even the recent patient which we did last month, she had only a violent cough episode, and that resulted her compression of two vertebrae. So it happens. So the what is the treatment? Treatment is usually conventionally by our ortho friends, neuro friends, who are very much keen to fix all the fractures of femur, tibia, and any other bone of the body. They are usually reluctant to treat these fractures of osteoporotic, which should be treated as soon as possible, like all other fractures. So the usual treatment they advise are the immobilization, complete bed rest, हिलने मत दो माता जी को लिटाल करो, analgesic drugs, and treatment of osteoporosis. Initial symptoms tend to disappear in 4 to 6 weeks in many patients, but not in all patients. And let me tell you that these 4 to 6 weeks with the complete immobilization, that is absolute bed rest, is hell for the patient. So painful. And on the other side, that complete bed rest or immobilization increases the demineralization of bone. That means that it increases the osteoporosis further. So another indication is painful and malignant hemangioma. Or interestingly, just to inform you that first vertebroplasty in perhaps 1987, Neeraj sir will correct me if I am wrong, was done by Dr. Gilbert. And it was for the hemangioma only. And that is also at the C2 level. So they used, Dr. Gilbert used in Switzerland. He used a uh, transoral route to reach the C2 vertebra for the hemangioma. Third indication, I told you, multiple sclerosis, multiple myeloma, and the metastasis. Here you can see this is the classical picture of metastasis. This is also a classical picture of metastasis. I will tell you further how to differentiate between the normal osteoporotic uh, bone and fracture and the metastatic fracture. So, little bit a word about of painful spinal metastasis. Radiotherapy is considered to be the mainstay of bone metastasis, including the vertebral metastasis. They do, our friends in the radiation oncology, they do palliative radiotherapy for this kind of lesions. But there are few limitations, and they are very important. And what are they? It usually requires 2 to 6 weeks to become effective. That means even if patient is getting the palliative RT, most of the time it takes at least 2 or up to 6 weeks before they get meaningful pain relief. which is the aim. And if the patient is with limited life expectancy, so that becomes useless. And sometimes many of these patients have already reached to the upper limit of their radiation, so they can't even be given palliative art. So what happens, what usually happens in the clinical scenario in day-to-day life, that patients are being denied of radiotherapy. They haven't been sent to us pain physicians for the cementoplasty or vertoplasty or kyphoplasty, and they are just being put on the some zoledronic acid and some analgesic here and there and crying all the time. So now I will come back that what we do and why this vertebroplasty, kyphoplasty, also known as cementoplasty, because we are essentially putting the cement, and plasty means repair. So we are putting the cement to repair. So the exact mechanism, why should it provide pain relief? It's a very common question you will encounter in your life many times. तो डॉक्टर साहब क्या हुआ, आपने 2 ml सीमेंट डाल दिया, पेशेंट को रिलीफ क्यों आ गया? So we need to understand that exact mechanism of pain relief is still debatable across the board. But the pain relief is excellent and sustained. This is one of the few MIPCs which we pain physician provide to our patient, which where if there is a pain relief, which is the case in most of the patients, it is sustained. Second is endoscopy. If you have removed a extruded disc or you have done a posterior decompression by the PSLD, so it is going to last till another there is a recurrence or there is another level which is getting affected. So most acceptable theories for the pain relief after the PVP and BKP are mechanical theory, that filling of cleft and mechanical stabilization between the of fractured part of the vertebra. They provide strength of the vertebral bone and thus causes pain relief. If you just try to correlate with the femur fracture or tibia fracture, you must have heard the stories that there are local chiropractors और हमारे एरिया में पहलवान बोलते हैं. So they simply put two bones together and cover it with some kind of bamboo sticks, खपच्ची हमारे यहाँ बोलते हैं, just to keep them in line and to make them movement free, so they become painless. Second is thermal theory. As when the cement gets hardened, it is a exothermic reaction. And it is believed, it is known that temperature raises up to 80 to 100 degrees centigrades inside the body, which is likely to ablate the newly generated uh, neuronal fibers in the fractured area. So it is also another theory which is considered to be cause of pain relief. So after the indications, now we come to the anatomy. It is very important part, and all your mentors, including me, Neeraj sir, Anshul, all everybody will inform you, tell you that if you want to be a successful pain physician, proficient in various MIPCs, it is as it's utmost important that you know your anatomy, because without anatomy, not only the simple anatomy, fluoroanatomy, USG guided anatomy. So you need to learn that very hard. huh? So spinal column, spine can be translated into the or divided into the three parts: anterior column, middle column, posterior column. In anterior column, you can see that half of the part or two-thirds of the body of the vertebra is this is the anterior, this is the posterior where you can see the spinous process. So this part is considered to be sorry, anterior column, hmm, which includes anterior longitudinal ligament, anterior half of the vertebral body, disc, half animus. Middle column. Middle column includes the posterior half of vertebral body, this part, disc and annulus corresponding, and posterior longitudinal. And third is posterior column, which include the facet joints. You can see ligamentum flavum here, posterior spinous process, interconnecting ligament. So, what are our area of interest? So, most of the time, our area of interest is this anterior column fracture, these fractures. Sometimes, after you get experienced, like Neeraj sir will tell you his special technique, of fixing the posterior column, middle column fractures as well in few selected cases. But if the fracture is involved in this posterior column, they can't be fixed by the percutaneous methods yet. No, no. They have to be, if they have to be fixed, they have to be sent for the open surgical fixation to our surgical colleagues. So our area of interest majorly anterior column, then in some cases, selected cases, middle column, and what is no is posterior column fracture. Then again, just to amplify that point, that spinal canal and cord are located in the posterior column. I told you an anterior half, anterior column, very much of our interest. Uh, Middle column up to the posterior part of vertebral body, again in selected cases, our case. But this is the danger area where spinal canal, cord, all the nerve roots are situated. So fracture in the element in the posterior column, yeah, I have already told you that if the fracture is here, or fractures here, it is likely to impinge upon the spinal cord, corda equina, neural roots, and they are not your cases. Because what happens if you put cement recklessly here, and God forbid, it is already compressing on the cord, and your cement also leaks there and increases the pressure. The patient who is still the neurologically intact one, in spite of fracture, may becomes neurologically unstable. So another view of the same thing, uh, it is important again to understand that, as I told you, the first vertebroplasty was done at the C2 level. So here it is important. So that means that these MIPSs can be done at all levels, but at every level anatomy is different. So your approach also need to be changed. So please see, this is the thoracic vertebra. Here you can see this is a conical type of vertebra or triangular shaped vertebra, and it is the lumbar vertebra. So this is more of rectangular type of vertebra. So it is very important to see the shape of vertebra before you attempt this, because this will decide your approach for these advanced MIPSs. Here you need to understand this is body, this is pedicle, this is spinous process, facet joint, vertebral body. So you need to check the anatomical landmarks before you venture into the vertebral kyphoplasty. Also, it is important is the orientation of pedicle. Here you can see in the thorax, they are vertically oriented. Okay, but here they are quite big and they are usually slanted, tede hote. So this gives you different approach. Again, then comes the X-ray. You start again, you try to check where is the fracture, uh, anterior column, middle column, posterior column, see for the canal. On the AP picture, because most of the time we use the transpedicular approach, I will tell you. So you need to identify the pedicles. Are they intact? Seems to be. But lamina, spinous process, disc. So you have to check these X-rays. So indication we have already done. Indication. Yes. So now comes a very contentious question. So most of our literature, old literature especially, it suggests that the correct time of mm, vertebroplasty is after the conservative care of 4 to 6 weeks. But uh, current wisdom is that when we do not wait 3 months for the femur fracture or the tibia fracture, why should we wait for a spine fracture if we can fix it in the minimally invasive percutaneous manner, which has the potential to provide a wonderful relief with the restoration of quality of life? So why not? So there is no absolute criteria, but now most of the pain physicians practicing across the world believe that they should be employed as early as possible in the acute or subacute fractures to enhance the quality of life. So, but it is also said that more than 3 years, 3 months old fractures are less likely to be benefited. So, as for the most of the diseases which we treat in the chronic pain, uh, they all have papers in their favor or against. So, in that scenario, the literature suggests that more than 3 months old fracture, but we all have experience that depending on the MRI finding, depending on the clinical finding, many patients do get better with this. And what happens, like what I was just telling you, that the old literature, the traditional literature suggests that you should wait for 6 to 8 weeks before you employ the PVP or BKP. But this is our own experience where you can see that there is a fracture of L1 vertebra here. And this is after 3 months of the conservative care, when the patient was supposedly immobilized, this become the condition, just to enhance the understanding. This was the fracture, which was a cakewalk for any pain patient who is doing vertebrokyphoplasty. It becomes almost a vertebra plane, difficult, and with the conservative. So this is the one more reason. Then now the literature suggests that we should do it as soon as possible. So we have talked about the indications. Now we come to the absolute contraindications. So the contraindication, as I told you, the posterior column fracture, and sometimes with middle column fracture, especially if the fracture is burst with posterior wall destruction, which is more common in either metastatic type of fracture in comparison to osteoporotic. In osteoporotic fractures, you see this kind of fractures when they are neglected. When the patient has been advised the bed rest and he or she is not taking it properly, then sometimes it happens. But it is very common with metastatic fracture. And also in the high velocity trauma patients, it is very common. Pre-existing neurological disease. If the patient is already in the cardiac coil, so it is advisable that it's better not to do these interventions, rather to get a surgical reference for these patients. Considering two things. One is clinical, where you may increase pressure unwittingly and worsen the neurological deficit. Or neurological deficit is still there, but patient or their relative start saying that this is because of you. So even if you are doing with a mild kind of neurological deficit, it is very much advisable to do the proper consent taking and better get a surgical reference done. Fracture related spinal canal stenosis, when the fracture is protruding, a part of fracture is protruding into the spinal canal and causing compression of neural structure. When there is not the matching between the patient pain and the radiological lesion. Sometimes it happens when the patient is having fracture on the X-ray as well as on the MRI, but there is no point tenderness, there is no clinical feature related to that, and patient is complaining of some other pain. It also happens sometimes. So that patient are also not the right one. Coagulation disorder. So they are the common thing. Infection. These are the common contraindications. And last, which is allergy, history of allergy against the contrast media or the polymethyl methacrylate cement which you are going to use. What are the relative contraindication? Previous spinal canal stenosis. If there is a, so you need to make patient understand that your kyphoplasty or vertebroplasty is not going to take care of patient's all pain. Patient might be having claudication because of the spinal canal stenosis at L4-5, L5-S1. And currently patient has come to you with the acute pain because of the compressed fracture of L1. So it is very important that you make patient understand that, look, what was your condition of claudication beforehand? It will remain the same even after my fixing your fractured vertebra, because this is the patient common tendency. They feel that they have spent money, they have undergone your MIPSI, and their whole pain has gone. So this is one thing. Second is damaged pedicle or transarticular facets. That means that most of the time I will come to that. We use the transpedicular approach. If the pedicles are damaged, then what to do? So it is considered to be relative contraindications because there are multiple another ways of doing the vertebrokyphoplasty safely. But you need to be a bit experienced. To start with, we all start with the transpedicular. So this is the reason it has become the relative contraindication, not the absolute. Height of vertebra. Most of the time, it is considered that the less compression is a better patient for the fixation. Like if you see in the Europe and America, most of the post you might have seen on some LinkedIn or Facebook. So the fracture is hardly 10, 20, 30% at the most, or hardly 50%. So if the fracture is, the height is more than 60% loss, 65% loss. So they say that it's a relative contagion. Again, if you are experienced enough, you know few tricks of which Neeraj sir is a master of. You can treat any vertebra plana, anything like that. But again, in the initial period of practice, it is advisable if height is too less, too planar, perhaps it is a relative contraindication for the new and novice. Soft tissue extension of metastasis and posterior valve cortical defect. So this is again very common with the metastasis of the spine, metastatic fracture of the spine, when there is the metastasis is involving the vertebra as well as going into the iliopsoas or somewhere else, and there is a defect in the posterior valve. So there is a difference between the defect and destruction. I will come later on. Poor cardiopulmonary status. If the patient is completely moribund, already ASA5, then difficult to make prone, difficult to lie prone for 1 hour. So it is again relative contraindication on the case-to-case basis. And non-availability, I would change the last point slightly. Previous multiple surgeries or obesity may cause poor visualization of osseous structure under fluoroscopy. It depends more on your fluoroscopy. So as a pain physician, you all are spending 1 year of your life to learn the fine niche of MIPCs in pain medicine. So you must ensure afterward you get a good CR on the level of cath lab. What is cath lab? It's a high-end CR. So that kind of CR you require. Not of that even, but still a good quality CR is a must to do. So what I was telling you about the defect and destruction. So here you can see the right picture, and I hope that you can make out that this whole area has gone. And here there is again a metastatic fracture which is going into the soft tissue, but it is also the posterior wall is breached, but this is a small area. So this is defect and this is destruction. So this is not our case. Absolutely not. You do whatever you can do, but cement is ultimately going to leak into the canal and there will be a catastrophe. This is also come under the relative contraindication due to two reasons. Because here it is going into the soft tissue. You can see this metastasis. I hope that you can make it out. And there are likelihood of going it in. But still, it can be managed tactfully. Even when you are experienced enough, you are using a balloon or vertebral stenting or something. So this is the difference between the destruction and the defect. First one, destruction, absolute contraindication. Do not attempt. This is relative contraindication. If you believe you can pull it through, go for it. Another contraindication, tumor extending into the epidural space. Here you can perhaps make out this tumor is going into the epidural space. Yes, it is already compressing the cord. So even if your cement doesn't leak, you put the cement here, and even if it doesn't leak, there is good chances that this cement will push this soft tissue further into the cord. It will increase the intracavitary or intraosseous fracture, your cement, and it will, if the patient is on the brink of neurology, it may land into the neurological complication. So it is also a absolute contraindication. Another contraindication, again in the line of uh, metastatic fractures, osteoblastic lesions, very common with the carcinoma prostate. And how you can find out they are osteoblastic, I will tell you, but you need a CT scan to find it out if you are having some doubts. So, but the osteolytic Fractures, they are beautifully calibrated. So here you can see this is the high sclerose part, metastatic, very painful, but unfortunately, currently we can't do anything for him with our vertebral kyphoplasty. But here you can see discrete lesion, osteolytic. You can very well provide him wonderful pain relief with only 1 ml of cement or half ml of cement. So what are the imaging studies required before the PVP and BKP? So the story starts always with X-rays, simple plain X-rays. आजकल plain होते नहीं तो digital X-rays, where you find that there is a compressed vertebra in the lateral view. Then you go ahead. What to do next? So always you can see there are two vertebrae who are fractured. One, two. This is also going down, not completely fractured, but still yes, it is like. Now the question arises: how to find which one is to fix, or uh, do we need to fix every fractured vertebra we see on X-ray in every case? No, it's not. But what's the use of X-ray? So X-ray is wonderful modality to see the primary survey of the interpedicular distance, to see the integrity of pedicles, to make out the osseous structures. Here you can see, and the shape of vertebra. So what is the fracture it is involving? It is anterior column largely. So this is wedge compression fracture, most likely due to osteoporosis. Hmm. Now comes the MRI, which is the investigation of choice in these kind of patients. So never ever attempt these kind of MIPSs in any patient without a MRI at hand. That too a recent MRI at hand, not 2 years back or 1 year back or 8 months back. So get one X-ray. Because why? This tells you whether the fracture is acute or chronic. This tells you about the extent of disease or in the epidural extension. It tells you where to put your cement, whether you can do the vertebroplasty or you should offer only for the kyphoplasty, whether it is involving any chance of infection, like it happens. X-ray showing a fractured vertebra, two fractured adjacent vertebra, and when you get the MRI, you find that it is spondylodiscitis, most common due to tuberculosis in our country. So MRI is the investigation of choice. How? So you can see that this may be all the sequences are important, T1, T2, and most important sequence for these particular set of patients is hysteremesis or T2 fat suppressed growth, one and same thing in large understanding. So these are the so T1 images, T2 images, and hysteremesis or T2 fat suppressed image. They tell you about the fat suppressed means T2 fat suppressed. T2 means where there is water is white, and fat suppressed. And fat suppressed. So fat suppressed where fat is suppressed. So whatever you are looking at, which is looking bright on the T2 fat suppressed or hysteremesis, it is likely to be edema because this is water. That tells you about the chronicity of the fracture. If you can see that there is high signals in the T2 fat suppressed images, you can be assured that fracture is still active, though there can be history of 6 months to 8 months or 1 year. If it is there on the fat suppressed image, it is likely to be active. MRI also tells you about the type of etiology of the, it gives you an idea of etiology of the fracture. Is it osteoporotic or can it be metastatic? And metastatic fractures do have a tendency of a bulging posterior wall into the canal. Here you see, they have a tendency and they are usually multiple. Like here in this MRI, you can see 1, 2, 3. 3 vertebrae we can see here. So there are multiple level involved in the metastatic fracture. Third thing, what you see in the axial picture as well as in the sagittal pictures, you see the extent, whether it is going into the epidural extension. Here you can see, I think. So these are, you have to be careful about them. Then comes the CT scan. So there are two indications for that. Rarely it happens that your patient can't undergo the MRI. It happens rarely nowadays because most of the implants, dental implants or the orthopedic implants, are usually MRI compatible. But still, you find some patients who, because of their implants or their pacemakers, they can't undergo the MRI. Hmm. So then you have to take a call based on the clinical pictures and the CTs. So this is one indication for CT scan. Another very, very common and very important indication which you all must remember is when there is a doubt regarding the posterior wall defect or destruction, especially in the cases of metastasis, sometime in the cases of osteoporotic fractures as well. If the fracture is neglected, you are not sure about the osteoblastic or osteolytic type of metastasis, then CT is the savior because it shows you bone boundaries very clearly. It shows you about the sclerosis. Like this fracture is, you can see the rim, sclerosis rim, and in the between black hole. So this black hole is osteolytic, this is osteosclerotic, and this is a mixed type of fracture. It is still our case. But if it is complete sclerosis, as I told, shown you earlier picture, it is not our case. Here you can see it is a quite almost 50% of posterior wall has gone. Again, not our case. Here you see that the almost all the posterior wall has gone, not our case. Again, another patient. Here you can see that we were talking about the we were not in the MRI. You see, you are not able to make where are the fragments. You may attempt it, but again, when you get the CT scan done, you find there is a fragment which is going ahead, which is not a problem. Even if it is pushed further a little bit, it's not going to work. But what about this fragment? It is already in the canal, compressing on the cauda equina. So you don't want to touch this fracture. This is a burst fracture. So in these cases, CT scan is important. So now comes to the treatment. It doesn't, what I am telling you so far doesn't mean that you should be ready with your Jamshidi needle or kyphoplasty temp. Uh, as soon as you see the patient, you jump on it and poke it there. No. Treatment still starts with the tailor's brace, conservative care, especially during the time when the patient is undergoing the required investigation. It takes time. If you advise today, patient will go and get MRI done. You check it. You again advise for the CT scan done. Then some blood investigation. So and sometimes there are patients who actually doesn't need anything because the fracture is so low, so little fracture, and patient is young. Patient is not osteoporotic. So you don't want to put cement in those young patients. You want to give them a fair chance of conservative care. So there, the normal lumbosacral belt is not enough. So you need to do the ash brace, which is spinal, anterior spinal hyperextension. E is missing, sorry. E is, so this is ash brace and this is Taylor's brace. So you need to keep the spine in the extension so that the fracture gets fixed and in the right posture. So now comes to the part again to our MIPC, that is percutaneous vertebro and kyphoplasty. So there are few technical pearls and positioning. So the patient which we do, some of you must have seen our ortho and neuro friends doing kyphoplasties and vertebroplasties in general anesthesia. But as a rule, I believe across the world, we pain patients do them under local anesthesia only. Even sedation is not required in most of the patient. And that this ability of us pain physicians to be able to do them in the local anesthesia only gives us a significant advantage because we can fix any patient even of whatever age, even of whatever ASA grade is there. If a patient is alive, patient is responsive, we can fix them because we are not we haven't any fear of general anesthesia putting the tube. Patients may or may not come out of the general anesthesia. So we are doing it under local anesthesia. But the patient should be able to lie prone with cylindrical cushion, one under the chest and one under the pelvis to achieve maximum extension of the spine. Please remember, uh, in most of our MIPCs, with which you start, facet joint, MIPC, transfemoral neuroplasties, and all these things, you put a pillow under the abdomen to decrease the lumbar lordosis. Here the aim is different. And why is different? Because of this picture. I will come back. Yes. So fracture, where it is fracture? In the anterior column. So what we want to get them opened. And it happens in many patients. When you make the patient prone with the increased lumbar lordosis, the end plate opens up if the fracture is acute or severe. So this is the reason we put two pillows, one under the chest and one under the pelvis to achieve maximum extension or increased lumbar lordosis. And as always, in all the interventions which we do, especially the advanced type, there must be a possibility of converting the intervention to open emergency operation. That means practically that someone has to be there on your back. So it happens. There is nothing great about it. It happens with cardiology. It happens with gastroenterology. Everywhere, we are a medicinal branch who do interventions, but there has to be someone who will take, if the need arises, uh, he will or he or she will take care, help you, as you help them in their cases when they are getting complicated. And yeah, this is my personal suggestion. Always use the best available equipment. Do not try to save few pennies here and few pennies there. Hmm? Because that makes your life easy. And good quality equipments are really better. Once you use them, you will find. So now comes to the approaches, transpedicular approach and parapedicular approach. So as I told you, the transpedicular, that means you are going through the pedicle. So this is the picture of lumbar vertebra. You can see rectangular shaped vertebral body, big size pedicle. You are coming from here through the pedicle into the vertebral body. And then comes the parapedicular. Here where you are not going through the pedicle, but beside the pedicle. So they have their different reasons when the pedicle is not visualized very much, when the pedicle is small, when the pedicle is straight, uh, then you use the parapedicular approach. But there are risks, few things which may go wrong with parapedicular, like the cannula, because here you are going in less of soft tissue part, then you're going into the bone. Here you are going all through the muscles, iliopsoas and all that. So there are chances of sometime uh, hematoma formation if you haven't compressed it. Then these approaches, both of these approaches can be either unilateral or bilateral. Hmm? So one from this side, one from this side, or this side or this side. The aim is to fill the complete vertebra or the complete cleft. So if you are seeing that your needle position is not very good, it is not reaching up to here in the midline, you should put another cannula. Like here you can see that both of the cannulas from one vertebra to other vertebra is reaching near the midline. So it's a good likelihood that this cement filling from both of using both the cannulas will provide you wonderful fill. So again, that part of technique, the classical teaching is cannula insertion and at the superolateral angle of the pedicle. Hmm? But gun barrel view can also be used. So I will show you. So here, uh, if you can see, this is the pedicle. If you cut it down, 1, 2. So this becomes your superolateral quadrant. So if the patient is in a prone position, your CM is the AP view, you start from here. Your cannula will come here. And it will go slowly up to here. And intermittently, it is the single most line important. If you want to remember one line after this presentation, please remember this, that in AP view, your cannula must not breach the medial pedicular line. I hope you all can make this is the medial pedicular line, this is the lateral pedicular line, this is the mid pedicular line. So please remember, अपने मन में दोहरा लो कि in the AP view, your cannula must not breach the medial pedicular line till in the lateral picture you have reached the posterior yes. Posterior is here. Here you can see that guide wire has still to reach the medial pedicular line. I hope you can make it. And it has already reached the posterior vertebral body in the lateral position. Now you are free. You have to check only in the lateral and go where you want, up to the anterior one-third of the vertebral. So please remember this line. In again, I am repeating it. In AP picture, your cannula must not breach the medial pedicular line till in the lateral fluoroscopy picture, your cannula has reached the posterior vertebral line. So you please remember this line and you will never land into a problem with this thing. So what is the end point of the cannula insertion? For the percutaneous vertebroplasty, we take our cannula in the lateral picture up to the junction of anterior one-third and middle one-third of the vertebral body. Here you can see, I hope, this is the anterior border of vertebral body. Okay. So you have to go up to there only because this is the area which is devoid of Batson's venous plexus, which decreases the chance of venous embolism. But in the balloon kyphoplasty, your cannula stays in the posterior one-third of the vertebra. I heard of that. Your balloon tab, for which you make a cavity. We will come. So I have already told you the end point is anterior and middle and third junction of the vertebral body, which is devoid of venous plexus. Only after satisfactory placement of your cannulas into the vertebra, you start opening your cement and preparing. Okay. If you want to do a unilateral pedicular or bipedicular, whatever cannula you want to place, you place it beforehand. Only after that, you open your cement and start mixing. Okay. And you mix it till the cement reaches to the consistency of toothpaste. And only after reaching that consistency, you start pushing it through the canal. So there are multiple systems available with different vendors to assist you uh, injecting the cement. Hmm. So this is again use step ladder pattern. There are multiple adjacent fractures. So because these are all the kyphoplasty, vertebroplasty cannulas are having big handles. So you better to use the one from here, one from other side, step ladder pattern. Hmm. Sometimes now again there is a contentious issue. Sir will put more light on this. Sometime before injecting the cement, many of our respected seniors, they like to put some dye before putting the cement, which tells them about the venous leakage, which may happen, or a small leakage into other places, like in the posterior wall defect or something like that. I personally do not use the dye. There are two reasons because of that. Because the consistency of dye is consistently lower from the cement which we are going to use. That means that in a small hole, in a small vessel, where the dye will go, like here you can see the dye is going into some vein, a small vein. It is unlikely that my cement will also go into the vein because cement is way thicker than that, especially if I am using a kyphoplast. Or if the small hole is here, dye may leak, but cement is unlikely to leak if I am cautious enough. Hmm. So I do not put. And venous leakage, if it is there, if you notice it, stop. It is likely to be seen by the cement within a minute or two, and then you go ahead. And third thing, again, one most important thing, always put your cement slowly, gradually, and in live lateral fluoroscopy. Again, please remember this line, another line, in live lateral fluoroscopy. Never ever do this thing that you are putting 2 ml of cements and then you going to take a shot and check whether it has gone. Because if it has gone to some bad place like in canal or somewhere else, you can't do anything, my friend. So cement has to be injected This is a fluoroscopy intense job, let me tell you. But that is the price you pay for the safety of your patient and yourself. So always put the cement in the live liter flow. So now little word about the balloon kyphoplasty. Again, they are both one and same thing. The aim is same, indications are same, everything is same, except it is slightly more invasive than the vertiplasty. But there are good things. Balloon 10, there is a specialized balloon which is put into the vertebra to create a cavity inside the vertebra. And uh, it also believed that it restores the height of fractured vertebra, compressed vertebra. And because there is already a cavity made by your balloon temp, the thicker amount of cement can be pushed, which is not possible in most of the cases when you do only the vertoplasty. Then you need to use slightly more liquid cement in comparison to balloon kyphoplasty. So that gives you an as a benefit of less leakage of cement with the balloon kyphoplasty. So cannula placement in balloon kyphoplasty is absolutely similar to percutaneous vertoplasty, where again I am repeating my line that do not breach the medial pedicular line in AP picture till you have reached the posterior vertebral line in the lateral fluoroscopy picture. So cannula, ये line को याद रखना है. इसमें you can see that we are going. We haven't reached. This is the picture I showed you. Medial pedicular line is still 2 mm away, and we have already reached the lateral vertebra. Good. Then you stay there, as I told you, in the here. You stay at the posterior 1/4 or 1/3 of the vertebra. Over this guide wire, your cannula is gone. Through this cannula, because your drill is handheld drill, which we use sometime to make a place for the balloon temp, which is replaced by the balloon, which you see two markers here and here, and then you inflate it. When you see both markers out of the cannula inside the vertebra, then you start inflating it with what? Radiopaque dye, which you use commonly for remixing. You check it, you see the restoration of height, you see. Then you deflate this balloon, take it out, and fill it with the cement. So this is the final picture which you can see, which is this. This is looking like little leakage in the disc, which is actually not. Here you can see it is still in the vertebra. So what are the end points of filling? Are the passage of cement beyond marrow space. If you are seeing that enough cement has gone, the vertebra is filled. And second is cement reaching to the posterior quarter body. Because what I told you that uh, at any place, cement leak here, 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 it looks bad. It should not happen. But it is not disastrous. God is kind. It is not going to harm. But what is bad? The cement leak is there. I will come to that. So once cement is injected, it is allowed to harden. Needle is removed only with a gentle motion to ensure the cement tip is separated from the tip of the cannula. Then you compress the wound to achieve hemostasis and keep the patient room for at least half an hour or 1 hour before the cement completely hardens. What is the amount of cement to produce pain relief, which is again uncertain. The traditional literature in the early 2000 suggests that 1 2 ml 3 ml cement is good enough, which is actually the case. If you are obtaining aiming only for the pain relief, usually 1 to 2 ml cement even provides a wonderful pain relief. But as the current wisdom suggests that we should try to restore the height of vertebra as much as possible, so it is advisable to use more amount of cement. So we started with 1 2 ml of cement in our initial cases. Now currently we are putting 9 to 8 to 10 ml of cement in a lumbar vertebra easily after doing the kyphoplasty. It is not possible in most of the cases with simple vertebroplasty. You know? So same about the maximum number of levels to be done at single sitting. Again, it has been suggested more than 3 levels of vertebra should not be attempted to fix in one go. Perhaps the reason was considering of the cement embolization and cement reaction, which is also at some point of time was common. Post-intervention, post-MIPSI vertebroplasty, a CT scan or X-ray is advisable for the medical legal purpose. So now comes the complications. As I told you, the only complication which usually happens apart from the anaphylaxis or something like that. So most of the complications with these MIPSIs are intraoperative. Fortunately, this is also something which we can control in most of the cases that we are vigilant on. So the most common complication is this is leakage of cement, and where cement can leak, it can leak anywhere. In the old vertebrae, it can leak into the through the end plate into the disc, upper disc, lower disc, anteriorly, and here you can see in the disc it is going slightly anterior. Here it can go posterior, which can be disastrous, which must not happen. But that doesn't mean that it doesn't happen anytime if you work in it. It happens. But at that time, it becomes important. And at this point of time, it also became important of my second line, which I requested you to remember. Cement injection only in live lateral fluorescence. The reason for that is that so that you can see where your cement is going in the live lateral, and you stop as soon as you see that cement is going posteriorly into the canal. So this little amount of cement is looking bad, it is looking disastrous, but it is still non-consequential. By the God's grace, it is unlikely to produce any neurological symptom or requirement to open the spine immediately. Another complication which also happens, which is again fortunately clinically non-significant, again non-desirable, it is uh, embolization in the lungs through the Batson venous plexus. And there are literature which suggests that it happens in large number of patients unknowingly uh, and clinically insignificant. But again, the important line is when you see that cement is not staying into the vertebra, it is going somewhere, find out where it is going. Stop, check, only then go on. And what are the bad complications? I was telling you about the complication should not happen, doesn't look good, but fortunately clinically insignificant. So these are the bad complications. These are the bad. You see, the cannula was not going through the this is a thoracic vertebra. You see the rib, you see the pedicle. Perhaps the cannula went through the canal, both sides. So perhaps it harmed the uh, mm, cord while passing it through, and then cement also came out through that cannular thing and completely quashed the cord. So this patient must have gone through the paraparesis and requires the immediate surgical exploration, removal of cement, and hoping for the best. So this is bad complication. This is bad complication. Again, cement is not leaked into the canal. So patient is neurologically intact. But it happens for the reason I told you that always remove the cannula after shaking it down so that cement get detached. Or you put the trocar inside the cannula before you remove the cannula after filling up the cement so that cement does not track through the cannula. Here it is happening. It has happened in my first case of kyphoplasty in 2014. So, so it's not a neurologically important problem, but this is a nagging problem. I had to open that, dissect it, and remove that cement. Still have it with me as a souvenir of my first case and my first complication, but God is great. So this is different, slightly more advanced for the bone metastatic lesion in the spine, pelvis, ilium, and abhi currently we are not putting the cement only in the fractured vertebra, but we are also using it for the bone metastasis of any bone, I am telling you, be it ilium, ischium, femur, humerus, clavicle अभी मिला नहीं है कोई, but है. So it is also a wonderful MIPSI which provides immediate and remarkable pain relief to these unfortunate patients. Hmm. So these are few of our cases where you can see that we have put cements in the distal femur. Here you can see. The patient was immediately full weight bearing. But you can do it only in the epiphyseal region, matlab two ends, not in the metaphysis. Because if it is in the metaphysis, the shear energy will fracture the bone, long bone. So it is advisable only in the long bones, in the other side. So this was the sacral metastatic. I hope you can make out in the left side sacral ala as well as the D4 fracture. Severely painful, unable to sit. So we did the vertebroplasty of the D4 vertebra with the sacroplasty of this. Multiple myeloma, multiple levels. So you can treat them, and they also provide wonderful pain. Then I was telling you, as you get more experienced, you learn from other mentors, your mentors, you become confident. You can see that it is going slightly back, but patient was neurologically intact, and we thought of doing the kyphoplasty or vertoplasty because patient, we took a leap of faith because patient was not ready for the open surgery, and we were sure that it is not a metastatic fracture. So we did the vertebroplasty and almost a restructure, I can say, of the vertebra. Again, bone mats, which was unresponsive to the radiotherapy as well as the strontium therapy. So multiple in the step ladder, which we told you. So, mm, so another extreme vertebroplasty, you can see this is the complete, sorry, sorry, vertebra plana. And we were fortunate that her end plate separated and we got a wonderful cavity. And you can see that almost 8 ml of cement was used to fill her completely. And there was complete almost reconstruction of the vertebra. So the efficacy, the osteoporotic compression fractures, up to 90% patients experience dramatic or complete relief of pain within several to 72 hours of patients. In fact, after 1 hour of your MIPSI, patient gets wonderful relief. You ask them stand, they stand. Neoplastic compression fracture, again, more than 80% patients, their requirement of narcotic or complete pain relief. Look, in the cancer patient, pain is not because of a single pathology. There are multiple pathology. Then if it has been metastasized to the vertebra, that means it has metastasized to other organ as well. So your vertebrokyphocementoplasty is not going to take care of whole body pain. So, but the major chunk is coming from this fractures. Your cementoplasty is going to provide relief from that part of pain. But for another part, certainly their analgesic requirement will be reduced. So what there are few assumptions like these vertebral and kyphoplasty are contraindicated in moderate to severe with propulsion of posterior vertebral cortex into the spinal canal. Again, I showed you one of my case. Minister will explain his own unique method of the dealing with these kind of cases. But we are not suggesting you to start with these kind of cases. These are just to know that yes, this can also be done and your time will come. Loss of more than 50 to 70% of height. I have shown you vertebral planner. Restoration of height, better results. It is again a questionable thing, but currently I can tell you across the world, most of the people are aiming for a restoration of height. And why? Not because of better pain relief, but because of avoidance of ASD. What is ASD? That is adjacent segment disease. What is that? That is adjacent vertebral fracture. So the current wisdom is that when you try to restore the sagittal balance and coronal balance after restoring the vertebral height by using a kyphoplasty or balloon stent, something like that, there are less chances of ASD in the future. And volume of cement matters again, I have told you. So the take home message is that balloon kyphoplasty and percutaneous vertebroplasty are MIPSIs to decrease pain and more importantly, to improve quality of life. If you have seen some patient of these fractures, you will find then because they are old, in most of the cases, old elderly females, in most of the cases, sometimes males as well, they are afraid to eat. they are afraid to drink water. Why? Because for if they eat, they have to go to toilet, and for them even to sit or walk to five steps to reach the toilet is so painful. They stop eating, they stop drinking water. So because their bathroom visits become more less frequent. And but again, post procedure care. So no post procedure care except if you don't treat the underlying cause of vertebral fracture, which in most cases is osteoporosis. Then you have done a half job. You have actually done a something wrong with your patient. So it is important. It is your duty as a pain physician, qualified, trained pain physician, that you know how to do the diagnosis of osteoporosis, how to manage it aggressively. It is very, very important. So for that, you need to how you get a BMD DEXA scan done, you need blood work done, and you must start the anti-osteoporotic treatment, which nowadays a wonderful anti-osteoporotic treatment in the form of teriparatide, romosozumab, uh, denosumab, and multiple others are available, and you must start them. So to summarize, these MIPSs are definitive procedures. They are very less complications if you are confident enough using good equipment, right patients, and very safe. Oh, ये तो- So this is my institute where I work, Dr. Ramanohar Lohia Institute of Medical Sciences, Lucknow, Uttar Pradesh. If you visit any time to Lucknow, you all are welcome to come. Oh, sorry, I missed one last thing. That about the cement. I was supposed to tell you, I missed those slides. So cement is, as you all know, that it is two part, polymer and monomer. So one part, both are made up of PMMA, polymethyl methacrylate. Hmm. So you mix them aseptically. Again, I am telling you because multiple vendors, multiple companies make different type of systems where you can mix those both of the things without touching them with the no touch technique, which again enhances their sterility. Also, very important to remember that these MIPSs, they are not small things. In surgical books, they are considered surgeries. In our pain medicine, we consider them MIPS. So, but that doesn't mean that you can do them without a proper aseptic care. Your hairs are going here and there. Your mask is down at your chin. You are not washing it properly. So please never ever attempt that. Because practically you are implanting the patient. You are putting an implant, which is cement. And God forbid, if any infection goes with it, that the patient's life and in turn your life will become hell. So that point I am trying to emphasize that take the utmost surgical level uh, aseptic measures while you are attempting this. Second point from my side, in the initial period of practice, always try to do the bipedicular approach. Always try to do the bi. It may tempt you that अरे नीरज सर तो बस एक बार में डालते हैं मिड लाइन के भी अक्रॉस पहुंच जाते हैं है ना तो वो अभी सर से प्रेरणा लेना है यू हैव टू गेट इंस्पायर्ड बाय द मास्टर्स बट your time will also come. In start with to do the right proper job, please do the bipedicular approach. Then third thing, I was telling that cement after having made up of PMMA, they have got barium sulfate, which is a radio-opaque marker. Because please, it is also very important to understand that always use the cement which is made for the uh, these specific purpose of vertebroplasty and kyphoplasty. I would not suggest you to use the cement which is commonly used by our ortho and neuro friends because what is the difference? We are using cement in the liquid consistency and they are using cement in the semi-solid consistency and that makes lot of difference. Hmm. So, and what is the difference between the two cements? The surgical side cement which we are using, it is having only 10% barium sulfate, barium hydroxide, sorry, uh, weight by volume. And our vertoplasty and kyphoplasty cements are usually having 20% weight by volume, uh, barium hydroxide, so that it becomes visible even in the liquid condition. So you want to, as I told you, that you all must inject cement only the live little fluoroscope. So this is something. So these are the few things which I can share, and any sir will end it. So thank you for your patient listening, and Anshul,
Yes, sir.
sir,
Yes, sir.
so I am done,
Dr. Anurag,
sir.
what a wonderful talk, I must compliment.
Oh, thank you, sir. Thank you.
Wonderful talk, Mother. It's something to learn how
RS.
coolly and how best you can, pass on the message to the
Yeah.
people who may be novice or people already doing it, but with such a contentful and such a variability in the kind of fractures which you will manage so well.
Later in
I think my compliments to you to begin with.
Thank you, sir. It's so kind of you.
It's such a learning thing because I learned something that is an implant, is a non-metallic implant, which I never
Mhm.
thought in some time, but it's a non-metallic implant, truly
Mhm.
speaking. And should not
Yeah.
never ever get infected because then you can't remove this implant, it
No,
becomes a
you
mess.
can't.
You can't remove this implant. Wonderful. All safety precautions are to be taken for sure. You can't take a chance when you're putting an implant. And all the more a reason because the surgeons are waiting to blame, so you don't want to be blamed anyway by any chance.
True,
Be
sir.
it a disc
True.
procedure or be it a cementing, But
Mm.
very, very good, very comprehensive, very well covered, and with a range of different thought process which can come up in the fracture scenario. Yes, I loved your talk. Believe me.
Thank you. Sir, please add
Good.
something which I've missed something. I've left
No, no,
something.
no, 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 no.
So
You really
please.
covered it so well. So I was thinking if we can add something more, but you really covered it so well.
Mhm.
Well, the few points which can be taken into consideration is always cool the OT number one,
Yes.
and cool your cement preferably a day before, not in the freezer, the sub freezer section. So cement as well as the monomer and polymer both. So when you make the cement, make it a cold saline, ice cold saline, so that cement stays liquid for a little longer. So you get a more procedural time. The mechanism is the biomechanical mechanism is that cooler the cement, the longer it takes to harden. So maybe it's 5 minutes, 10 minutes, 20 minutes. The procedure time we're talking,
Yes.
and inside body it get into 37 degree at no time, within
Yes.
minutes. So that's where you are clogging the veins and all. If it gets into vein, stop for 30 seconds or a minute, it'll clog by itself and you can start putting more cement without being worried of any leakage for that matter. So that's the secret or trick, or trick of the trade.
Yes.
So a cold cement is very, very vital. I have advised and I do see sometime when you don't get a good opacification of the cement, I put the Redupac dye, Omnipac dye, and I've used it for last 20 years or maybe more, without maybe 22 years by now, without any issue with the cement hardening or cement strength, and with a very good visibility and almost you see the first drop of leak if it is going anywhere in the vein or anywhere through the cortex or upper or lower end plate. So you can really adjust your procedure accordingly. So this is one thing which I devised and I've put on the world forum few times. Well, it's said it's a physical consequence of a biological disease. Must treat osteoporosis aggressively because it's like a dentist treats your one tooth for RCT. He always asks you to brush all of the teeth so you don't get more, of those caries. The whole
True. True.
story lies is that when you have those 33 vertebrae, you've got one fracture, you want to safeguard the other ones. It's a must to treat as a rule. When you treat one fracture with cementing, treat other fractures or other bones before the fracture with the osteoporotic management, which has to be aggressive enough. So I think it's a beautifully talked and very well covered topic. There's so much we can talk for hours together, but for all people who are sitting there, I think you're lucky you got this lecture in a very smooth line way, very, very smooth and very cool way. So it was going through and through, from one head to other head. That's very, very wonderful. From so like a song goes from soul to soul, same way the vertiplasty has gone from head to head. I'm happy that it has gone so well. Again, my compliments, my dear friends.
Thank
Uh, God bless and Dr. Rag, I think you did a great job.
you. So
Somebody
just your
calling me on
blessings,
my
sir.
number.
It's your
Yeah,
blessings.
yeah, yeah, yeah. So keep up, and keep teaching the generation to come.
Yes,
And
sir.
I must say, it's one of the best MIPSI procedure. which gives
True.
an instant and permanent relief and almost complete pain relief to people who are dying in pain, and they may die on bed also if we don't treat them, especially
Yes,
spinal osteolytic fractures.
yes, yes.
And I tell you, the bad part of the society is these happens to older people who are loners. They're by
True.
themselves. Kids
True.
have gone. And the old couple is lying alone. One person gets a fracture, other starts caring, which oneself can't manage by oneself. I've seen people crying out of the social agony, out of the not physical agony, also social agony, that who is there who's going to take care of those
Exactly.
old people. So I do feel all these people who have been assets to our society, they become suddenly a liability if they get a fracture and get into bed. What has happened to the fracture hip with all those common splints you have seen for 6 months and a year, and people used to die, and a prosthesis has done the job. Same thing has happened with the fracture spine. You do it, instant relief, and patient is back to life. So I think probably that is desired from all of you who are sitting in the hall, that learn it well, and do it really perfect way, because there's a lot at stakes.
Yes.
So please, it's an important procedure. This is a beautiful talk, I must say, and a lot has been covered from corner to corner. And you are lucky that all aspects have been taken care, right from the ease of the procedure to complications and difficult procedures, and what all can be done. So I think I'm happy that I could listen to the talk, and could really see that how best it can be delivered.
Thank you, sir. Thank you for the
I'm happy
kind
with
words.
that.
Thank you for
Lovely.
the kind.
Sir, there are
Any
some questions.
time anybody can ask, anything comes up, There are few questions around, I think it seems
Yes,
there
sir.
is. But if there is enough cement spread, the unipedicular approach will be enough, right, sir? Or you call?
Yes, sir. Yes, sir. Yeah, but as I told you, like if you are confident enough that unipedicular approach you have reached to the midline or past the midline, and you are sure that the other side of other half of body is going to be filled, then it's the approach. Yes, unipedicular is the way where which is economical by money, economical by time. But again, as I told you, you don't start running after the birth. So I suggest that you start with the baby steps, but it is up to you. Certainly, if the aim is to fill the cement in the both part of the vertebral body, if you can do it unipedicularly, good. Sir, you would like to add
I
something?
think, yeah. So I was about to say that I initially used to do bipedicular, but I'll give you one very interesting finding. When I started putting cement from one side, it started regurgitating from the other needle. You see?
Yeah,
So
it
the
also
whole
happens.
idea
Yeah.
is it's the same cavity they both are addressing.
Yeah.
So when you're trying to put cement on one side, if it's already going to the other side, same will happen from the other side. So I stopped putting the second needle in first go in a good number of times. Then I can go across midline. So I put cement from one side, see how well it is can be managed and filled, and some manipulation with the needle. If it is adequately done, great. You think it's still not good enough, then you put a second needle in, and you cement from the second side. And what I advocate is you don't make whole cement in one go.
Yeah.
So what I do is either keep two cement in the fridge, always keep a spare cement in the fridge, or I make half and half cement. I make half cement first, which is good enough for one vertebra. And if you think the other side has to be done, make another cement, another bowl, another half cement, and then put from through the second needle. So that way, it really kind of economizes the procedure, and it eases the procedure. Why put two needles? Because after putting needle, transpedicular has caused some injury, has caused some trauma to the pedicle also, and it ideally should be avoided if it is not really required. It's not a luxury to use both pedicles, because pedicle after all is part of the important body structure, and is a strength of the vertebra. So unipedicular is initially is good enough, but if you think it's not good enough, then, but as you said initially, and which is very wise, that in the initial beginning it's important to be safe, so start doing bipedicular. And another advice on that is start from the lower lumbar vertebra. There is a wide
Yeah.
pedicle, less of the chance of leakage. And even if it leaks, it is very forgiving, because the spinal canal is very roomy there. Very less of neural structure and a lot of CSF. So it's roomy, even if some leak is there, it is forgiving. And
Oh,
that builds up your confidence. Then you start going upper, then you're
good.
going slow dorsal, it's always better.
Yeah. One line, sir. For the reason I asked them to use bipedicular is slightly selfish one, because I know with my experience that in the initial days of their practice, they hardly get very frequent patients for the vertebral kyphoplasty. So when they put two cannula, they get twice
They get more
experience,
confident.
more confident, more experience. So this is the reason I always ask my fellows to
Yeah.
start with two.
No, no, good. And
So this,
ideally speaking, you start from the left side. Normally, because we are the right-hand people,
yeah.
so left gets easy. For left-hand people, right gets easy. So that can be done. Another question was, after how many days of fracture, vertiplasty and kyphoplasty should be done? Very nice informative presentation. I think probably it has been talked, you well informed,
Yeah.
but still you want to enlighten.
Yeah, sir. I would like to share my own personal family experience of just 1 year back. My mami ji, uh, I hope everybody understand who is mami. So my mami ji got a fracture of L1 vertebra. I
Mm,
came to know day after the injury and her pain. She went to an orthopedician nearby to the place she lives. He, as usual, advised for the teriparatide and the absolute bed rest with some analgesics. She was absolutely not relieved. And from the day I came to know about the this news, I was like troubled. मामी जी को ले आओ भाई, I will fix her. मुझे पता है इनको ले आओ. Still, it took 9 days before I could convince my family, they are my extended family, to bring her to my place so that I can fix her. And you believe me, uh, we did, and we did a vertebroplasty actually. Her fracture was quite acute, ninth day it was. It was hardly 20% fracture, but severely painful as usual. And we did the vertebroplasty, and after half an hour, when she was sitting in the post-operative ward of my place, then she told me, बेटा मैं आज 9 दिन बाद खाना खा रही हूँ. मैंने इमिडिएटली उनके लिए कुछ खाने को मंगाया था. आज मैं 9 दिन बाद खाना खा रही हूँ. Then I realized the gravity of the situation. 9 दिनों में उन्होंने खाना नहीं खाया था, उन्होंने पानी नहीं अच्छे से पिया था. She was just surviving somehow. So this is
it's a
the
fear of
agony.
passing urine and motion, because they can't move.
Exactly, sir.
And the
Exactly.
second is they don't want to cause social embarrassment to the relatives. All
Yes.
the people who are caretakers, that they will have to manage with the,
Pen or
urine
something
and,
like that. Yeah. They don't want.
yeah, exactly. They're trying
So
to
this
safeguard
happens
them.
in my own family. Then I actually the gravity loomed over me that it is so difficult for these patients. They need to be fixed, and we have to take care of them that they get better as soon as possible. So this is the
And
reason that
second question, Dr. Nag, why not? When you have such a beautiful procedure, why
yes,
allow them to
yes,
die in pain and live with pain?
mm,
There's no point. And like in your hands, and people already expertise the procedure. I think we should be more. I kind of push the patient. There are a few procedures which I push the patient to get it done. Normally we
true.
leave it to the patient advice and leave it to let them come and let them buy the surgery or beg for the surgery. But
Yes.
here I push them for surgery because I know this procedure is very
It is
rewarding,
going to
very
work. It is
safe.
going to work. Yeah.
It is going to work. But people don't know sometimes. The problem is they are not well educated and they have been, badly fed or wrongly fed by the other disciplines because they are asking for a screw fixation or surgeries, and the problem is uh, when you say you can manage without surgery, non-surgically, the acceptance on the other team people or
Yeah.
competitive team people is not good.
Yeah.
So that way, that thing is there.
Mm.
Another word was, so can we do vertiplasty in a case of refracture or post-vertiplasty fracture or osteoporotic compression fracture? Somebody's asking for redo, like a knee redo or other redos or spine
Yeah.
redo, a redo of a cementing.
So there's Dr. Sumit has asked this question. This is a wonderful question actually, but slightly far ahead for most of the people. It happens in few patients, rare patients. It happens, Sumit. Good you ask it, but and it is possible again. But sometimes you don't get the transpedicular route, so you use the extrapedicular, parapedicular route, or there is another route which is subpedicular route now in the market. So you can use it, you can do it, but I am telling you that after doing perhaps 500 cases, you will encounter one case, and it usually happens uh, with the patients there are my own patients. When I see their old X-rays, I feel ashamed. Man, what job I have done? I have gone only from due to my carelessness, my laziness. I have gone from one side only. I put some cement. My cannula was not that well placed. My cement was not that prepared so that I can put another cannula as sir has just suggested. So this is the reason when you do the half job done. If like I showed you one slide where the fracture was just under the upper end plate and you have put cement everywhere but not in the cleft. It hasn't gone into the cleft. So it is going to be a still to be painful comparatively. Immediately patient will report you wonderful pain relief, but patient will come back and inform you that there is still some pain. So yes, it can be done. It should be done. But believe me, as sir has already suggested you, it is not going to happen very soon. Sir, you would like to add something? This is
Yeah,
a
yeah. The rule of the game is never underfill or overfill the cement. Number one, or the fracture for the matter. Because underfill will always leave the pain or patient keep coming back. And if you overfill, you have more chances of a complication. And the second is the first shot is the best shot, ideally speaking. This is one of procedure, one and done kind of scenario, and that is forever for that same vertebra. But yes, very rightly said, I have seen few patients who come back again, either undone or half done vertiplasty, kyphoplasty, and still in pain, and patients still morbid. So you take up, like I do take up few of these refracture cases, and or even for that matter half filled fractures, and recently I saw somebody did a good vertiplasty by one's own standard, but I saw the post procedure MRI, and the cement was floating in the big lake of liquid which was inside the inflammatory liquid inside the vertebra. The vertebra was still open, there's a big lake of fluid, and there was some floating cement. So that's a half done thing that happens with initial part of the career with many of us,
yeah, yeah,
even
yeah.
including us,
All
that they
part
are
of
kind
game.
of fear complex of the leak. They do underfill, and then again the patient keeps coming back. So the whole rule of the game is never under or overfill, fill it optimal so that it stabilizes and the pain is taken care and it doesn't leak. And that comes with experience, and that comes with exposure. So you should always take help of the seniors like Dr. Nrag is sitting and
Uh,
others are sitting on me for that matter.
yeah.
And you can always have an idea. You can always pass those films, by the way, before you do such procedure. By the way, it's a real practical thing I'm telling. You have a cementing vertiplasty or first few ones, always send the images to an expert. Ask, is it right? What is to be done? What steps to be done? What care to be taken? And those nuances of this procedure, they will really guide you, because the good eye, people who have good eye, they can always catch what is going to be a right or wrong in a given case, and they can really guide you through. And then you can always ask, during the procedure, if I may need some help, I may call you, or maybe later on I'll pass on the images so they can gauge what kind of work you're doing, what's the quality of your performance of the procedure. It's a beautiful procedure for that matter. Believe me, I'm a fan of this procedure, because and I tell you one more thing. As a matter of fact, it makes you one up. There will many patients suffering for ages together, and suddenly you do one cement and patients walking very next hour. Means I've
Very
done six
natural.
level six level cementing and patient is smiling.
Hmm.
So these are few things. I give you one very brilliant example. There was a ex police commissioner of New Delhi, and he came with his wife, two level fracture. And I tell you one more thing, only one was reported L4. When I saw with my own eyes, L5 was also fractured. There was edema in the stir sequences and all. I could see there's L5 also gone. So I took her up to the procedure. This gentleman was little bossy, so but very nice otherwise, but a little bossy, like a little arrogant. I said, fine, we don't mind. We know the problem and we can treat. The rule is of the three things: a bad disease, a bad patient, or bad relative. If two bads are there, no. Right? If one bad is there, you can still manage. So this patient was good, and the fracture was easy for me. So a bad relative doesn't matter to me much, because I know myself. So once I finished the procedure, it went so well. Then I came to know this gentleman is ex-police commissioner of Delhi, and he's a very big in the home ministry. This gentleman. So that was one part. But because I knew the procedure, now this man is, give singing tunes all over. Doc Jan is wonderful doctor. He's a great doctor. He could pick up the problem. He could treat the problem in no time. My wife was suffering so much so, and my hospital owner, and he saw him, that he is there sitting in the room, and then he talked to him and he said, Doc Jan treated me. So that is the one up theory I'm trying to say,
Yeah, it's
and it
very
changed the whole
important.
scenario.
Yeah.
It is so, and my hospital owner is telling everybody, Doc Jan is doing wonders. So this gives you that 1 up plus, and obviously you are doing your right job, you're doing duty-fied job, and that gives you a right kind of recognition also, which you really need. The discipline, the specialty needs, and vertiplas is one procedure which really takes you way ahead of all others, because others maybe a very very good surgeons could be just doing the surgeries only, or through screws or fixations, for that matter, implants, which is not an ideal thing, believe me, until unless it is really required, truly indicated. But just because they don't know cementing, they start putting screws. So, which is not a wise thing. So, my advice is learn it well, do it well, and do a justified job. After all, you're here to do good for the society. That's important, by the way. Another question, Dr. Anurag, is any chance of SI joint pain post verteplasty? A good question you should answer.
Yeah. So yes, SI joint is a like magical joint, uh, and it get involved. I don't know the reasons, exact reasons behind it. It do get involved in many patients after any kind of surgery, especially after the fixation, and fusion surgery. And in some patients, I have seen it in some patients that it gets involved after the uh, spine fractures and vertebroplasty, kyphoplasty. Perhaps because there is again, it is important that you all young pain physicians who are still in the training, you must read about the biomechanics of spine, which we usually miss. हमारे समय में कोई बात नहीं करता था इसका, हमको नहीं पता था. But you must all read about the bio. So it is related to the biomechanics of the spine which get distorted because of these fractures. So yes, if the patient is complaining of pain, like SI joint involvement is one of the most common etiology of pain in the failed back surgery syndrome as well. I hope that you all know that. So it can happen. Sir, you
Yeah, in
want to take?
lumbosacral region, lower lumbosacral region, this is one of the important load distributor joint, the when we do a fixation and all, they always avoid L5 S1 for the same reason. The whole load will be shifted to the SA joint, so they avoid sometime L5 S1 fixation, but until it's really mandatory. Yes, it may happen, but it's treatable in a good pain physician hand who can do vertiplasty can always manage the SA joint pain as well. So that should not be a big worry scenario for that matter. But it's a good question.
Sir,
Yeah, very good
sir,
question.
should we do SI joint MIPSI in that patient like intra-articular or?
Oh, why not?
Yeah. Hmm.
Why not?
Okay, sir.
Usually it helps. Enough is that. Matlab, you do it once, they are good. Then they start walking. Look, make them mobile is single most important thing, apart from the anti-osteoporotic treatment. Rest of the things is being taken care by the nature, Mother Nature. So intra-articular MIPSI is good enough. If the pain comes back, if they are having prior SI joint pathology, SI joint syndrome, if it requires you do the radio frequency. So the algorithm is same.
Sir, usually after the vertebroplasty 2, 3 cases, we have seen that the patient is having pain on especially on the iliac crest and SI joint over that area laterally. So the patient is very adamant not to move. She don't want to move due to pain. So
Look, as I told you in my talk, that you are not taking care of all the pains of the patient. So this is part of your history and examination before the BKP or PVP. There can be multiple other causes. And then for the rest of the causes, you need to check them, elucidate them, find the pain generator, which is your primary job as a pain physician, and treat it accordingly. It can be SI joint, it can be facet, it can be another fracture. As sir told you a very important thing actually. मैं उसको highlight करना चाहता हूँ जो सर ने बताया about the police commissioner who was having a frank fracture, है ना sir? And second fracture was found by the sir, which was an impending fracture. So as a pain physician, it is your responsibility to learn how to read your MRI. You can't go by the report of MRI. Take my word. And I know that sir will second it. You have
Yeah,
to
I
read
think
it.
probably many time, we were got into a wrong foot, because the reports are so. I remember a case I was doing a kind of a neurologic block for the parietal area, and in a multiple fracture, refracture, we do sometime, in a very painful flail polytrauma patient. You want to at least correct the pain part of the trauma rib fracture multiple. So and this the D7 rib was posteriorly and close to the rib head was fractured, and he has whatsoever you're putting in a ESP block is getting into the paravertebral space or getting into the epidural space. So it can be very nasty sometime. I'm telling you because they've not reported well. As I mentioned, L5 was not reported, L4 was reported, but I fixed the both, so patient was fine. Otherwise, you fix L4 and pain is coming from L5, again you are getting bad name. Please,
Yeah.
it's so important because patient knows pain. Patient doesn't know what is inside, what is MRI
Ex
finding, you know. So patient knows only
Absolutely.
one thing and that is pain. So
Yes.
you have to understand. Another point here is when you get iliac crest pain, which is very, very common, Dr. Rao. What he
Yes, sir.
said was a very good question, practical question, which I do face many number of times. To understand, there can be other pain generators, number one, or can be subclinical fractures and other side microtrauma fractures, or a facet or pedicle fracture some other level, which is missed. Another thing which does happen is because of the little long-standing fracture, sometimes there is a mechanical failure at the segment, So sometimes the facial pain is good enough to reflect on those areas of iliac crest and all. So that is could be one part of the story, but see patient from all possible angles, which could be pain generator. And remember, patient will keep complaining until unless you treat the pain. So what I do lately is, if I find patient comes to me second time with the pain, I go and do a facet work also at the given level. I do level and above as usually we do it.
Yes.
So there can be facet arthropathy at the level because of the mechanical dearrangement of the segment. So this is one of the known factor which needs to be treated. I think this beautiful question which has been asked. Any other questions is good. Otherwise, Dr. Rag, you did a wonderful job today. Very impressive. Very, very
I
impressive.
just want to add one thing, sir, here for these fellows or FIAPM. That look, you are destined to become the primary custodian of chronic pain syndrome and chronic pain patients. You have to learn how to take the onus of your patient. You are not there to poke the needle. Putting needle is not a big job. You know, Neeraj sir can teach anyone in 1 week time. But how to manage it pre and post op, how to find it, that is the thing which you are here. So please use this time and later as well. And this is something which is distinctly different from the mainstream branch from where we are coming. Most of us are coming, that is anesthesiology. There we do not take
Backstage,
onus.
we're on the front stage now. So
Yes,
that
there
changes
is
the
no
whole
one
story.
in between you and your patient. Only
Yeah.
you and your patient. So you have to take the onus, just as Neeraj sir has just informed you, that you have to, patient knows only the pain, nothing else, nothing more, nothing else. Many times you have to convince, you have to shout at the patient and their relative that you have to take anti-osteoporotic treatment because they are many times unwilling to spend recurrent expense. If you are using a denosumab, it costs 10,000 rupees every 6 months. तो पेशेंट बोलता है यार अभी तो पैसा इतना लगा है अब उसको बाद में और भी करते रहे क्यों करें तो यू तुमको बताना है दिस इज योर रेस्पॉन्सिबिलिटी टू टेल देम कि भैया डायबिटीज होती है तो सारी जिंदगी इलाज कराते हो ना हाइपरटेंशन होता है सारी जिंदगी इलाज कराते हो ना वैसा ही है तो ये
Now, I've
तेरे
treated 10 fractures in a patient, in different timelines. So sometimes they are habitual fractures or a bad osteoporosis, which is kind of intractable. But otherwise, most of the time it is very much treatable. But still, you may have a, follow fracture maybe few months down the line or a year down the line. But if you treated them aggressively, believe me, most of the time it is taken care. So it
yeah,
becomes very, very vital because sometimes they'll come back with the adjustment level fracture. And they will come and blame you did the cementing level. That's why the next level is fractured. Tell them beforehand. It's a safeguard. Tell them beforehand. If you don't treat aggressively, you're going to have other fractures. Please tell
within a
them
year
all.
yeah within
I
a year
always tell the people because if they come back with another fracture, you are not to be blamed because you already pre-informed them.
Hmm.
So what you say in the beginning is you are informing. It's information. What you tell later on, it becomes defense.
Yeah.
So you don't want to get into a defense.
Word of wisdom. This line also you note down. The last line sir said. If you tell them anything you say beforehand, before you
Yeah,
touch the patient, it
yeah,
acceptable to patient. Whatever cost it requires. Anything you say after the intervention, MIPSI, you have done, it becomes a cumbersome, it's become a burden on the patient. That is the psych, which is also need you guys to be understood because again, you are coming from anesthesia background where you are not talking to the patient actually. None of us actually, not you, anyone who is coming from that background. So you need to learn as that as well.
that skill set has to be learned. It's so vital. It's a practice skill set which a GP may have better than the specialist, for
Much,
that matter.
much better, much better.
So that you have to inculcate and learn it and do it and be confident about it. And that really comes. If you know your job well, you can talk it out well. So Dr. Anurag, thank you so much
Thank you, sir.
for a
Thank
great
you.
job done. I'm so happy. So happy I
Thank
was
you.
part of this process, So happy.
Thank you, sir.
Mm.
So nice
It's a
of
pleasure.
you to share
Yeah,
your experience
I know.
and
I know.
Thank you,
Please,
Neeraj
please.
sir and Anurag sir.
Thank you,
It was
sir.
very
Hi, Dr.
informative.
Anshul. How are you? So I think it's late for people. You can always close it, call it a day. But there's so much of carry-on message. They must have a good night's sleep tonight. Many of those people. And there will be few enthusiasts who will want to sleep tonight because they want to do procedure tomorrow.
It's good. It's good for us, for our specialty, for our branch, sir.
Okay, dear. Good night,
Sir,
all.
Good
bye.
night, sir.
It's been a
Thank you, sir.
pleasure. Good night. Good night. Good night. Good night, friends. Good night.
Night, sir. Bye bye.
Bye,
Bye.
Anshul.
Bye.
Bye, sir. Bye, sir.
Bye. I am
Bye.
ending the
Bye.
meeting.
Bye.
Okay,
Good
sir.
night.